So our next speaker is Dr. Chitra Ramamurthy, and she's going to be discussing debates about, keratoconus and corneal ectasias and toric IOLs.
Can you hear me? Very good afternoon to. इसको बंद कर देते हैं. Very good afternoon to one and all of you, and mind you, in the next few minutes is to talk on toric IOLs in keratoconus and other corneal ectasia. Where would you indulge? Now, how is it that a toric IOL placement in these ectatic conditions need a special mention is what I'm going to take you on. The most important thing is the pre-operative considerations are very critical if you want to optimize the outcome in cataract surgery in keratoconic eyes. Now, what are the indications when you would implant a toric IOL in a case of KC? It's not coming there? If it is a mild to moderate keratoconus, you can consider. If it is a non-progressive disease, now more likely a cataract in that age group, there would have been enough natural cross-linking, so KC is less likely to be there. And these patients, if they are not dependent on a rigid contact lens to achieve a good visual acuity, it gives us a feeling that there is a likelihood of the astigmatism not being too irregular. We should also have an historical data that these patients before the inception of cataract had a good decent vision, and astigmatism that is not very irregular in the central 4 millimeter of cornea, and there is also a possibility that it's just a mild to moderate, that they may be fine, they may not need a corneal transplant, and if it has, or if a PKP has done, they should have regular astigmatism. These are the indications. When would you not do a cataract surgery, toric IOL in a KC? If it is an advanced KC and more though if it has a central scar because of eye drops, or if it is a young patient with a progressive keratoconus where because the cornea is still elastic and there's still ectasia to progress could happen, then it becomes crazy for us to get measurements because it is going to change in every axis and meridian. And of course, if a graft is being considered in future, then you would not implant a toric IOL. Again, whether would you plan if it is a centered or a decentered cone? In a centered cone, the chances that you would have put a toric IOL is more, but in a decentered cone, we need to know what is the extent of decentration and what is the irregularity in the central 3 to 4 millimeters. Again, if he is not a previous RGP or a rose scale lens user, and even if they have been wearing lenses, you need to remove their lenses and ensure there's a repeatability in the K values, and then only you go ahead and do the IOL power calculation. And if it is a little irregular cornea and you're able to talk to the patient and convince him to do a topo-guided PRK to regularize the cornea, or if you can do an intact segment and following that doing a cataract surgery would be a very ideal way to go. Now we have the different topographers, the tomographers, the Shamefunk device, the swept source OCT. So with all these devices, we are now able to identify keratoconus in nearly 5 to 10 times more than what we could identify before. And again, in this, we need to see whether the central 3 to 4 millimeters is not irregular. But if there is a steepening of the cornea far away from the central area, you could still implant a KC like in a pellucid marginal degeneration. Now, if a patient is a previous RGP or a low scale lens wearer, if it's a RGP lens, 2 to 3 weeks, they have to be off contact lenses. If they have been wearing soft contact lenses, 1 week. But if it is clearer lens, just 2 days off contact lenses is also all right for you to get fairly repeatable readings. But then, if they have been constantly wearing RGP lenses and they are only comfortable with that, probably it is best to do a non-toric monofocal IOL, because these patients, that means they have a significant irregular astigmatism, and by just doing a cataract surgery, you cannot presume that they will not need a contact lens wear. And I'll explain to you what would happen if you go back to wearing lenses after you've done a toric IOL. Again, repeatability in K measurements is a challenge. There could be a tear film abnormality in these corneas. So we need to regularize all of this. I mean, make the tear film more more smoother and more to get repeatable measurements. Then what happens if you are going to use standard IOL formulas? Now, the reason why the challenge is here is the ratio of the anterior to the posterior surface of the cornea, the ratio gets altered because along with the steepening of the anterior cornea, the posterior cornea is also getting steeper. So the normal refractive index of 1.3325 gets altered in these cases. So what happens is, if you are going to calculate the total corneal power in a pentacam or a total corneal net corneal power on a pentacam and use these values into the earlier generation formula, it will not do well because they have a different keratometric index and what has happened to the corneal index, keratoconus index, has changed. Again, the other important thing is, what happens in these eyes is the cornea is also has become steep. So the anterior chamber becomes very deep. So where the lens is going to sit is actually more posterior than it is going to be in these normal eyes. So even the effective lens position gets altered. So what happens then? What can happen is they could end up with little more of hyperopia after a cataract surgery, because not only have they an AC depth which is irregular, many of these eyes are myopic. So even in myopic eyes, you could end up with an overestimation and a hyperopic end result. So what has also been seen is, if it is a mild keratoconus, the hyperopic error is lower, and naturally, and if the keratoconus is severe, the end hyperopic outcome is more. Also, in these ocular keratoconic eyes, the inflammatory markers are more because the tear film regularity is more, and that itself can impact the K readings. Now, when it comes to doing the K readings, if your standard deviation is more than 2, that it's an indicator that you have to repeat your measurements. But even after repeated measurements, your standard deviation continues to be more, then what you should do is you should take the lowest value of K reading so that it ends to a little myopic outcome, because there's a greater challenge of ending up with a hyperopia. So you should try to avoid selecting a low power. Then the other important thing is, again, if the patient has been wearing a hard contact lens, clearer lenses, K readings we are not able to get it, try to aim for a little myopic target in your IOL power calculation. Now, as far as what happens to the posterior cornea, the posterior corneal astigmatism is contributing to the toric IOL power. But what happens in these eyes is, instead of the routinely being an against the rule astigmatism, here there is more likelihood of the posterior cornea to have a with the rule astigmatism. And again, as it was said, that you will find that it is better to follow the EKR value in your IOL power calculation than to go by the total net corneal power which is available on the IOL master or the pentacam, because they have a different refractive index. As far as the choice of IOL formula is concerned, therein itself is a great inaccuracy. Rather, the SRKT, surprisingly, was fairly consistent, and so earlier on, people used to use the SRKT formula for keratoconus because it used to assume that the cornea is more steeper and used to err towards a myopic outcome. Now, that is what we want in a KC, because you can get a hyperopic surprise. The Kane formula has also gained a lot of popularity, but in Kane formula, you don't feed in the total corneal power. You feed in the anterior corneal power into the Kane's formula, and then it would calculate the IOL power. And it is said that what they recommend is that if the astigmatism is stage 1, you do not alter the IOL power, but you aim for 0.7 to 1.5 diopter myopia as the end result. In moderate keratoconus and severe keratoconus, you try to leave the eye with -2 to -3 diopter keratoconus. And this graph tells us that the Kane's formula is doing pretty well and nearly as good as the Barrett formula which is available for the keratoconus, and you'll find that the SRKT is also coming close behind. Again, the Barrett-Truque formula for keratoconus is available on the APCRS website. Herein again, you have to feed in the anterior corneal power and allow the Barrett-Truque to predict the total corneal power. And again, different measurements have said that the Keynes formula, the SRKT and the Barrett's seem to be similar. So as far as the timing of the surgery, based on the kind of vision the patient has, you would do a topography, and based on the topography, you would decide whether you are going to put a toric IOL in this patient or you are going to put a monofocal IOL. And if the corneal surface is irregular, then you would decide whether you would do a topo-guided PRK intact and then go on to taking your IOL part. Now, this is just an example of a decentered cone, as you can see there. And after regularizing the topography, the central 3 millimeters is more regular and you can do a cataract surgery. Again here, again it's a decentered cone, and following an intact segment, the central cornea has become more regular and you are able to do a cataract surgery. When it comes to doing a cataract surgery, the intacts are largely in the 6.8 to 7.6 optic zone. So you can easily create a 4.9 millimeter capsulotomy on a femtocataract platform, in the sense that capsular rhexis is not going to come in the area of intacts. So you will not have any areas of uncut rhexis. The other important thing is sometimes these corneas can be so steep that you have to use a Trifen blue that will help you to pick up the rhexis better, or you could even leave viscoelastic on the cornea. Sometimes people even place an RGP lens, viscoelastic on the cornea, methyl cellulose, and place an RGP lens, and then they get a better visualization to do a cataract surgery in these eyes. With the PMD, there's less irregularity in the central cornea, so all you have to do is plan a customized toric IOL. Again, post-DALC or a PK, you need to wait till you are able to remove all the sutures, see whether you are getting repeatable topography and K readings, and you still understand that your aim is not emetropia, but you can go ahead and put a customized toric IOL. I'm just going to show one of these surgeries, like how you wait for the sutures to be removed. You make your incision beyond the graft, or sometimes you could make a scleral incision. You need to ensure there's enough viscoelastic to coat the undersurface to protect the endothelium. Keep your parameters low. These could be highly myopic eyes, so you have to keep your IOP ramp a little higher. Go in with the infusion, zero infusion, because there could be a reverse pupillary block which can occur in these eyes. And then, of course, do a good posterior capsular polishing and place the lens in these eyes. I'm not showing you this, which is all very similar. Rarely, you might have a refractive surprise, then you may have to do an IOL exchange or a piggyback IOL, but you need to have counseled your patient adequately. So I would like to summarize stating that you need to account for the posterior corneal part. You know that the formulas which work best are the Keynes formula or the Barrett formula for keratoconus or an SRKT if you don't have access to these. And you should look at the corneal power map before doing a topography. And why, if you have placed an if the patient, you've done a cataract surgery and he's not very happy with the vision, he wants to go back to wearing RGP lenses, and you have already implanted a toric IOL in these eyes, then you need to give a spectacle correction which will neutralize the toric IOL power inside. You understand? Because placing a contact lens on the cornea, it is correcting the corneal astigmatism, but the toric IOL is sitting there. So you need to give a spectacle correction which will neutralize the toric IOL power inside. That is why people who are very much on RGP lenses are not the ideal patient to put a toric IOL. They may be better off with a monofocal, and they can continue to wear toric IOL in the later years. I know what I said was a whole lot of complicated stuff, but I hope there was one or two take-home messages from this for all of you.
Yeah.
Thank you.
Thank you very much. I think if we would just say a couple of things,
Yeah.
I think counseling was very, very important, because
Yeah.
the patient will be very dissatisfied.
Counseling is very important.
Yeah.
Your IOL power calculations can go a little haywire. You might end up with a little hyperopia. So you try to leave a little myopic outcome and choose either an SRKT, Keynes formula and Barrett formula for keratoconus, which will be there on APACRS website or ASCRS website. So these are the three main things. And of course, surgery has to be done carefully and assume them to be myopic eyes. Keep your IOP low because the rigidity of the cornea and the sclera is less in these eyes. So do a slow motion phacoemulsification.
And these patients also have these, some of them have the RGP lenses. That also gives us a little clue about the K readings also.
No, if they are wearing RGP lenses and they say they are only happy with the RGP lenses, you know that they have a more irregular astigmatism on the cornea. So that itself is an indication that these patients may not do well with a toric IOL.
Yeah.
So you might as well do a regular cataract surgery, put a monofocal IOL.
Correct. Thank you very much, Dr. Chitra.